Okay, thank you. I'm very happy to be here with you to talk to intraoperative radiotherapy in breast cancer. And since PBI was born more than 20 years ago, the clinical scenario in oncology and breast cancer dramatically changed, as you know. And certainly I could say that everything has changed in these last years and more quickly again in these last weeks, of course, of coronavirus. First of all, technology. Differently from the beginning, today, different technological tools are available for partial breast irradiation. This is very important. 3D conformal, intrabeam, brachytherapy, mammosite, and of course, intraoperative radiotherapy with electrons. Second, scientific data. New data are available today thanks to the effort of several groups in the world. As you know, the European Institute of Oncology began treating patients with intraoperative radiotherapy with electrons, so-called EIO, in 1999. And in 2013, we published the results of the randomized control trial comparing intraoperative radiotherapy versus external radiotherapy for breast cancer with a median follow-up of 5 years. And the results of the trial with 15 years of follow-up have been recently updated, and the publication is impressive. And last but not least, the standard approach of radiotherapy in breast cancer is quite different. When at the end of the 90s, PBI has been proposed with the aim to short the overall course of adjuvant radiotherapy and decrease the amount of irradiated breast volume, the gold standard of radiotherapy after breast conservative surgery was a long treatment of 30 fractions of 2 grays each. And this procedure took at least 6 weeks to months. Now, the new standard of care is much shorter and takes 2 or 3 weeks with the same oncological outcome, of course. In other words, today, PBI is facing to an absolutely different treatment. And we shouldn't forget this never. It's very important, in my opinion. Despite that, PBI still represents the true new in the treatment of early breast cancer and the big challenge for the future, especially reconsidering all our knowledge, procedures, guidelines, flowcharts in this dramatic COVID era, of course, as you know. But to achieve the higher efficacy of the procedure, 2 things seem to be very, very important. First, a precise radiosurgical technique, and second, a careful selection of patients. From the surgical point of view, let me tell you that every single step of the technique of EIO has been well standardized over the time, and the entire procedure published. Of course, you can find it if you like. And the radiosurgical procedure has 2 main goals: the precise target exposure, the so-called CTV, clinical target volume at the prescribed dose, and the maximum protection of the healthy tissues in order to reduce the toxicity on the tissues to be not irradiated. Probably in the past, we did not stress sufficiently this point, and it was a pity, really, it was a pity. But actually, I think that a proper radiosurgical technique is absolutely vital to increase the efficacy, as I said, but also to reduce acute and late morbidity, I don't know, steatonecrosis, fibrosis, for example, and to improve cosmetic results. In the slide, you can appreciate the clinical target volume, well identified and prepared after cancer removal and gland mobilization. And in the sagittal view, all the elements are present. The collimator, the gland already after the cancer removal, already mobilized and closed, including the protective device to avoid the irradiation of the thoracic wall. Second point is the proper selection of patients. Let me tell you that virtually all the patients with breast cancer candidate to conservative surgery could have a benefit from PBI treatment in different modalities, of course, and with different clinical indications, always according to the calculated risk. Both in the last years, the American and the European Society of Radiology and Oncology, ASTRO and ISTRO, provided a consensus statement regarding patient selection criteria based on tumor and patient-related features. Here we have the ASTRO consensus statement dated 2009. ASTRO divided and distinguished 3 different groups according to the risk: the suitable group, the cautionary group, and unsuitable group, considering clinical and histological features of the tumor. ISTRO did the same, but they gave us less selective recommendation, at least at the beginning, especially for tumor size and some biological characteristics of the tumor. But the concept is exactly the same. Not all the patients are unconditionally good candidates for PBI. And recently, 4 years ago, in 2016, the ASTRO recommendations were updated with small but important changes. Finally, they made their recommendation a little bit more selective and practically more similar to the ISTRO guidelines. What happens in our institution, in the European Institute of Oncology, where, as you know, we perform the largest number of EIOT ever. I'm talking about more than 9,000 EIOT in these last 20 years. Well, based on the results of our clinical trial, and of course, considering ASTRO and ISTRO guidelines, we have chosen precise clinical indication for EIOT, and 2 different options are available for our patients. EIOT full dose, 1 single intraoperative radiotherapy of 21 grays and no more radiotherapy, but another possibility is available, EIOT as Boost, 12 grays followed by whole breast irradiation. Let's see, when single dose EIOT, when full dose 21 grays, well, best candidates for EIOT full dose are, in our experience, and these are our clinical indications: postmenopausal patient with small cancer less than 2 centimeters, unifocal and unicentric disease, and in general favorable biology following ASTRO and ISTRO guidelines, and negative sentinel node. Let me clarify that sentinel node is sent for frozen section in this situation, right? Because negative sentinel node represent the necessary condition to perform EIOT. And probably this is the only situation in which we still do intraoperative evaluation of the sentinel node during a breast conservative surgery, as we adopted many years ago the Z11 criteria. Full dose is especially offered in several special clinical scenarios. For example, in case of previous breast radiotherapy for Hodgkin disease, for non-Hodgkin disease, for a previous breast cancer treated with a conservative surgery and recurrence, or in severe cardiopathy, or in other conditions. You can see hypertrophic scar by skin burns or dermatological disease. When whole breast radiotherapy after breast conservative surgery is not indicated, is absolutely or relatively indicated, EIOT represents the only possible option to avoid unnecessary mastectomy in our opinion. EIOT Boost, 12 grays, when? Well, EIOT Boost is proposed in the other less favorable situation as premenopausal patients or postmenopausal patient with bigger tumor more than 2 centimeters, multifocal disease, or unfavorable biology, or positive sentinel node. And of course, in this case, an intraoperative evaluation of sentinel node is not needed, because it doesn't modify our surgical and radiosurgical approach. In other words, every time breast conservative surgery is indicated, theoretically, EIOT as Boost can be performed. Just to be clear, EIOT Boost means 12 grays followed by 13 fractions of 2.85 grays each, or in the more favorable disease, only 8 fraction of 3.6 to 4.0 grays each every day. So it's a very short treatment. And we know again that these boosts seem to be a very effective procedure in selected patients. So in conclusion, in the context of risk-adapted radiotherapy, the key to success is the proper selection of patients considering clinical variables, age, menopausal status, tumor size, focality, or histological and biological characteristics, or hopefully in the future, the simple molecular profile of every single patient. For the question if is it a little bit utopic, perhaps, probably, but that is what we are working for, the proper selection of the patients. The stratification of patients according to the clinical phenotype or by molecular class, and the widespread use of all the preoperative diagnosis tools we have, ultrasound, mammogram, MRI, might be better identify patients eligible for radiotherapy. PBI in the different modalities, full dose boost or hypofractionated whole breast radiotherapy, or locoregional radiotherapy, or maybe no treatment because probably exists a small group of patients in which radiotherapy is not useful at all. Thank you very much, everybody.